I'd like to welcome you to a small video podcast on the update of the metastatic and muscle-invasive bladder cancer. My name is Witjes. I'm a urologist from the Netherlands, together with Van Heijden, also urologist from the Netherlands, and Richard Cathomas, he is a medical oncologist from Switzerland. And we'll just be talking about some of the updates we have in the 2024 guidelines. Let's start, Twan, with local imaging.
Yeah, local imaging. We have added a part about MRI in bladder. That's a part especially for 3 Tesla MRIs using virus. We know that CT is not good enough to differentiate between T1 and 3A bladder tumors. MRI is superior. And we added a recommendation that if you have an MRI and that isn't 3 Tesla MRI, and you can use virus scoring system, it's good to do that just before you perform a TURBT.
Yeah. I heard yesterday in the discussion that one of the limitations obviously is the experience of the radiologist. So that's something I guess we have to work on. Yeah, we have to work on, and we have to gain more experiences and do more studies, clinical studies, to prove the actual value of MRI. Yeah. So Richard, and I had a discussion yesterday also that we also used it to see the response to neoadjuvant chemotherapy. Is that something that you envision as something for the future?
I actually think that is really an important question. And since the MRI is really helpful in assessing the response, as we have seen, there are these NEC virus classification as well. You can really judge whether the patient has responded or not. And I think with the novel agents that will also come into the neoadjuvant space, EVM Pembro most likely, we will have better responses, and we will need to assess if the patient still has muscle-invasive disease or not, together with a cystoscopy and some urine cytology.
Okay, but suppose that with the new drugs, there's a very good complete response with MRI maybe, or biopsy or cytology. Could that translate into some kind of bladder-preserving strategy?
This is potentially a thing that we can foresee for the future, but we need to prove that in trials. And there are several trials ongoing. I think outside of studies, this is really experimental. And for the time being, this should not be used, especially since we don't have so much experience with the actual restaging after neoadjuvant chemotherapy. Yeah. And we cannot really be sure if the patient has non-muscle invasive or muscle invasive disease. So for the time being, this is something for the future, but I very much hope so that it will turn out like that.
But without any doubt, you as a medical oncologist will get those questions from patients like, doctor, the tumor has disappeared, so what now?
We definitely do. And this is why I think this restaging is so important. And MRI is part of it. Probably ctDNA assessment will also be part of it. And so together with all the new tools that we have, we will hopefully be better in assessing whether a patient has complete remission with the systemic treatment already. But as I said, this is something for the future.
Okay. And if we're going to do some bladder preserving strategy, Twan, what do you think about?
Yeah, we could do, of course, trimodality treatments. But the question is whether you have to do that if a patient is ctDNA negative and has a negative MRI in the future. Maybe you should go on and put those patients on surveillance.
Yeah. Personally, I think ctDNA is a very potentially good marker. We had a session about that yesterday, and Peter Black was against, of course, he was asked to be against ctDNA. And he showed a slide, all the proof about ctDNA, and it was a blanco slide.
Yeah.
Because actually there is not real proof, although the IMvigor 010, the IMvigor 011 suggests that there might be a place. Where do you think we will be going?
Yeah, but when you look at the study from Assoc, for example, is a very strong predictor of presence of disease. So I can't imagine that it will not be the marker for the future.
Okay.
Actually.
Same for you, Richard? Yeah.
I agree. I think this is something that will certainly come in the future. But as you say, we need more data. And we are collecting this data as we speak. And it's not ready for prime time and for the guidelines, but it's something that we need to keep a close eye on.
Okay. Say, and for trimodality treatment, you do need a radical TUR for...
All the strategies for trimodality treatment advise radical TUR. And if you look at results and you look at the complete results rate, then it's significantly better when you perform a radical TUR compared to those patients without a radical TUR.
Okay. But I know that you're doing a trial now comparing radical TUR for potentially invasive bladder cancer with MRI and biopsy. Is that then worse?
No, it's No, but that trial has another focus. That trial is to diagnose muscle-invasive tumors, and most of the patients are still treated with radical cystectomy and not with trimodality treatment. And the study is powered on 75% of patients undergoing radical cystectomy.
Okay. So that's a different objective.
Yeah.
Great. So Monday, we are now living here on Saturday in Paris. And on Monday, I have to chair a session on no dissection. You know, of course, the 2 studies that have been done. With the guideline, we did a systematic review, I would guess 6, 7, 8 years ago.
2016, I think.
2016, yeah. And then the results were actually not very convincing because the level of evidence of all the studies that had been done was retrospective and small and not enough. Then we had the German trial in the end of the last decade, which didn't show a difference between an extensive no dissection, however you define that, by the way, because there's a lot of discussion how extensive is. But still, it was a good trial, extensive versus non-extensive. No advantage of the extensive. And Seth Lerner is going to present the Assoc trial, and exactly the same, extensive versus non-extensive. There's no difference in outcome.
No.
And what you do see, what I was a little bit surprised about, you have more morbidity. Well, that might be the venous thrombosis part, which you might have more with a larger lymph node dissection, but also higher mortality. Any explanation for that? And it was significant in both trials.
Yeah, they do show a higher morbidity and mortality rates, especially in the Assoc trial, the Canadian US trial. A 2 times higher chance of having 2 times higher chance
mortality. Yeah,
2 times higher mortality chance.
But why? And again, morbidity I sort of understand, but mortality.
The results haven't been published yet. It's from the ASCO 2023.
Sure. But I've seen the presentation of Lerner because I'm chairing the session.
Yeah.
And again, the mortality is indeed twice as high.
But maybe that is due to the thromboembolic events.
Yeah, maybe. Yeah.
That's the most logical explanation, I think.
And the German trial now has 6 years of follow-up, and there they see that the progression-free survival is better in the group that had an extensive no dissection.
Yeah, but it didn't reach the significant,
you're right. Yeah.
The 15% significance.
Yeah. So what would now be your advice for fellow urologists with regard to a no dissection?
I think based on the results we now have, you should do a standard lymphadenectomy up to the common iliac arteries.
Okay, so that's how you define standard?
That's the standard according to the guidelines currently.
Okay, because again, the definition differs quite extensively between studies and series.
But what we did in the publication in 2016, the systematic review, we defined standard as up to the common iliac arteries.
Yeah, I think that makes sense. So Richard, then again, a lot of news this year, like last year and the year before and next year, on your job, medical oncology, chemotherapy and immunotherapy. So what's the update? What's the news? What should we as urologists take home?
Well, for the metastatic disease, indeed, there has been a lot of changes. 2023, we have seen the presentation of 2 major important studies, the EV302 trial and the Checkmate 901 study, and they have now completely changed our guidelines. And we have changed the guidelines accordingly. Actually, ESMO has done the same, and NCCN has changed their guidelines, so we are in line with all other international guidelines as well. And it is clear that based on the results of EV302, which tested the antibody-drug conjugate enfortumab together with the checkpoint inhibitor pembrolizumab, so the combination of the 2, comparing it to our previous standard and our standard for the last 3 decades, platinum and gemcitabine, you can actually double the overall survival. You can increase the response rate by a whole lot. You can triple the complete response rate. So this is really a huge step forward. This is not just a small step, and this is why all the guidelines have taken over the combination of EV plus pembrolizumab as the preferred first-line treatment. There is a problem there because it's so far not yet approved in Europe. So it's not available for everybody.
Okay.
It's approved in the US by FDA. There are some countries in Europe where it's already possible to use it, and for that reason, we have also included a guidance of what do you do if EV and pembrolizumab is not available. In that case, I think
Pembro is available, I guess. But
Pembro
EV
is available as a single agent.
Okay.
EV is available as a single agent, but the combination of the 2 is not approved for the first-line treatment as yet. Okay. I hope very much that in 2024 we will see EMA approval, and for that, then in many countries it will be possible to use this combination, since this is a major step forward.
Talking about that, Richard, you know, you're also long enough in medical science. Based on only one trial, isn't it a bit scary just to totally change the guideline?
I kind of agree with you, but I really think this was a very well done study. It was a large trial, 800 patients. It was done in Europe, in the US, outside of these countries. It is very well balanced. The control arm with platinum gemcitabine, 30% received avelumab maintenance as well. And so it is really perceived as being a practice-changing study. And this does not need any confirmation, because the results, it's not a little bit better. It is literally, it doubles the overall survival. It goes from 16 to 32 months. And this is also what has been shown in a previous phase 1 study, the EV103, with 2 different cohorts that also looked at the combination of EV plus Pembro. And in these smaller studies, we see the same results that we now see in the phase 3 trial. So I really think this confirms what has been shown earlier on. Okay. Having said that, this combination is not so easy to use. I think we need to be careful. First of all, there is the toxicity from the immunotherapy. We're now used to that. But EV adds in some different kind of toxicity. And if these patients are not followed up closely, you can really run into troubles, especially with skin toxicity, with neuropathy, and with toxicity that can have long-lasting problems. And so this is not an easygoing treatment, but it's a well-tolerated treatment. And I personally believe it will be possible to treat more patients in the future than we have been able before with a combination.
If we know what we're doing, it's probably easier to give than MVAC or GemCis, you think?
I definitely think so. It's certainly easier than a cisplatin-based regimen. Yeah. And even compared with carboplatin gemcitabine, which is by itself already very well tolerated, it fares very, very favorably. Especially there is much less myelosuppression, so you have much less troubles with febrile neutropenia, with thrombocytopenia, bleeding complications, and so on. This is a major advance.
Okay. And you mentioned another trial?
The other trial, the Checkmate 901, tested the combination of nivolumab, so again an immune checkpoint inhibitor, with cisplatin and gemcitabine. So there, the carboplatin patients were not included, and it could demonstrate an overall survival benefit. But this was in a smaller scale. The difference is around 3 months, but still it's significant and it's improving. And also the complete remission rate is doubled, and patients who achieve a CR, they have a very long duration of response of over 3 years. So this is also something very promising. No, actually, these patients receive 6 cycles, cisplatin gemcitabine with nivolumab right from the start, and then they continue the nivolumab as a maintenance.
Yeah. Okay. And as I've seen in the guideline, now the first advice is EV plus Pembro. Second, then, if you don't have EV or you don't have Pembro, the combination is GemCis with nivolumab.
Nivo for cis-fit patients.
Yeah. Cis-fit patients. And then now third, which was first already for 30 years, is GemCis or MVAC.
That's right. This is really the third. And in these patients, I still think if they have a stable disease, they need to switch on avelumab maintenance afterwards.
Yeah. But that we already had in the guidelines.
There we already had it in the guidelines. So actually we have 3 level 1 recommendations now for the first-line treatment. And this is really a completely different as just compared to 3 years ago. So that's amazing. Yeah.
Also makes it more difficult or different to choose the second-line therapy.
Oh, yes. This is an important point indeed. Since when you use I would say the best combination first, which we always want to do, but what is left then? So all experts believe, even though we have not much data on that after EV Pembro, we should go on and give the patients platinum gemcitabine, most likely, if possible, if there are no contraindications. But also, I think this also highlights the importance of testing for FGFR3 mutations, because 2 trials last year, the TOR studies, showed that, in fact, FGFR is a predictor of response to an FGFR inhibitor, erdafitinib. And this also yields an overall survival benefit. So therefore, I think all patients with metastatic disease, if ever possible, should be tested for FGFR mutation so that you know what can I use in the second or later line treatment.
So in short, there are a lot of new possibilities for patients with definitely better outcome.
Absolutely. And I think this is why really these patients need to be discussed at the multidisciplinary team meeting. And they need to see a specialist and that can advise them about the best treatment and the advances of these treatments.
Okay. Guys, a lot of news. Did we forget anything which is of importance to our listeners and viewers? Twan?
No, I think the most important thing is the metastatic treatments we have now.
Yeah.
For sure.
And then for us urologists also, the notice section.
But we were already on the...
Richard, did we forget something?
No, I don't think so. I would like to emphasize once again the importance of MRI before TURB, actually. And I think this is also a very important step forward in assessing patients early on and putting them on the right way.
Yeah. Okay. Thank you both very much for a very good summary of the update of the 2024 guideline. And I hope you will enjoy this video podcast. Thank you very much.